Hi, my name is Dawn Tice, and I am currently a graduate student at Roberts Wesleyan College, finishing my Master's of Science in Nursing Education. This is a presentation of my capstone project, Preventing Preoperative Communication Breakdowns, a Surgical Services Project. I am currently working in the pre-admissions testing department at a local hospital here in Syracuse, New York. Our hospital roughly performs 11,000 surgical cases a year. I have been working in this department for 3 years, and prior to that, I was a PACU nurse for 11 years and worked in the surgical ICU right out of nursing school, which was almost 18 years ago. The purpose of this project is to improve the pre-screening calls that our pre-admission testing department currently conducts on all patients who do not come through our pre-admission testing department prior to surgery. The preoperative screening process is a vital and instrumental tool in a patient's surgical experience. Preoperative screenings, education, surgical instructions, and testing are all crucial aspects of preparing a patient for surgery. Our goal is to have a patient at their best possible health prior to surgery. Properly identifying risk factors through patient interviews is a complex process. It involves using in-depth questionnaires and probing medical questions. When important medical information is missed, the case study that I will be reviewing is one of our patients named Michelle. Michelle received a preoperative screening call from one of our pre-admission testing department nurses and completed a standardized screening questionnaire. Michelle quickly responded no to all of the nurses' questions in our questionnaire. That is an in-depth, lengthy questionnaire that has been built by our anesthesia criteria for our hospital. When Michelle was asked if she had any history of any cardiac problems, she quickly said no. The nurse who was conducting the screening call finished her education, her instructions, and the clinical setting in which this evidence-based practice change will be implemented is the pre-admissions testing department at St. Joseph's Hospital. The clinical problem is that about 2 years ago, we started to have an increased volume of screening calls. We took on the volume calls from 2 one-day surgery patient centers. The significance was we started seeing an increase in case delays and cancellations related to missed information due to missed information during the screening call process. This is a patient safety issue. Our goal is to have patients ready, properly ready before the day of surgery. Time for change. The pre-screening call process began evolving roughly 2 years ago. During this time, we had an increase in workload and volume. The processes and structures in place are currently not supporting the amount of workload. The patient population identified for this capstone project are the pre-operative patients who will be receiving screening calls prior to their surgery. The intervention consists of an evidence-based screening process and patient-centered educational approach using plain language and teach-back strategies to ensure understanding and OR readiness to best meet the standardized anesthesia criteria. The beginning of this capstone project entailed a very involved review of literature and body of evidence. The purpose of the literature search was to retrieve research articles related to my capstone communication project. The review of literature and body of evidence was focused in detail on teach-back methods and plain language techniques. The concept is that the negative impact of poor communication during a pre-surgical screening call and missed information between the nurse and patient, leading to surgical case delays and cancellation. Based on the review of evidence found for my capstone project, it is reasonable to go ahead and implement the delivery care model to improve patient satisfaction and improve surgical outcomes. These three emerging themes were all proven to be strongly supported through levels 1 through 6 of evidence found based research. Improving communication, teach-back methods, identifying low health literacy patients. These were the three themes which were all supported by levels 1 through 6. Implementing this preoperative interview process practice change will require the support of a strong theoretical framework. The theoretical framework that was chosen to help guide and support my practice change was the LEARNS model. This communication framework can be used to help support the communication between healthcare providers to overcome communication cultural barriers and successfully educate patients and families. The LEARNS model, which stands for Listen, Establish, Adopt, Reinforce, Name, and Strengthen, is the acronym for the intersections that takes place where the patient and nurse communicate. The steps that are needed to implement this evidence-based practice change in our department includes educating staff in teach-back methods, plain language, and health literacy identification. Using new teach-back method tools that will be built into our EMR record, during the screening call process, and the educational portion and instructional portion of our screening call. The staff will also be utilizing a new simplified anesthesia screening questionnaire that has been tailored to use plain language and prompt nurses to use follow-up questions to dig deeper into a patient's medical history. The key players include the change in practice step by step, as I discussed in the previous slide, is seen here in this graphic. Each step that will be implemented by the screening call nurse begins with educating the nurse in health literacy, teach-back methods, plain language. They will utilize the teach-back methods and the guidelines and tools built into the EMR system. They will utilize the new simplified screening questionnaire. They will also utilize the health literacy assessment tools. This is a three questions we will ask all of our patients prior to beginning the screening call. We will identify the patient. The purpose of this evidence-based practice change will include a patient-centered approach, as you see here in this graphic that I designed for my project. It is to improve communication between the nurse and patient during the pre-screening call. The four broad areas this practice change will focus on will be educating nurses to become health literacy aware, improve communication, utilize teach-back methods, and utilize new tools to improve patient care. The second area is utilizing concrete screening tools for identifying low health literacy patients and implementing new simplified screening questionnaires. Number 3 is utilizing teach-back method tools. Michelle's story, a demonstration of the implementation of our project. Michelle received a preoperative screening call from one of our screening call nurses who had completed the educational training classes that she had gone through. At the beginning of the call, the nurse asked Michelle 3 questions to assess her health literacy level and identify concerns and the patient's ability to comprehend the information needed to complete a risk stratification prior to surgery. The nurse identified that Michelle may be at risk for low health literacy and encouraged her to have a family member with her during the call. Michelle was able to have her mom listen in on the stakeholders meeting was greatly impacted by the current COVID pandemic and the effects it is having on my department that I work with. We currently are responsible now for all COVID testing for all surgical patients preoperatively. I was briefly able to meet with the stakeholders, which included my manager and the director of surgical services. Our discussion included how important this project is and the future plans for it. We discussed the impact of COVID on this project delay and the limited resources we have at this current time to be able to implement a new project. Our organization has put a hold on any projects that are anything newly related, and hopefully in the future, in the near future, they said hopefully 6 months to a year, we'll be able to implement. The cost for this project to be implemented entails training sessions for our staff, supplies, the IT department, changing and updating our EMR system, holding educational luncheons, and the total cost for this project to start would be roughly $4,540. Majority of the costs are mostly time related in regards to paying RNs to stay late, and the IT department was the information services department is the larger portion of the cost for this project to be successful. The current costs related to the clinical concerns are the costs related to a delayed surgery and canceled surgeries. The wasted resources, expenses, and emotional stress are also related to the clinical concern but are not displayed in this graphic. The total cost of this program is $4,500 to implement. The total cost nationally on average is $8,000 for a surgical case to be canceled on the day of surgery. Every minute a surgical case is delayed prior to going into the operating room due to the resources that are on standby, it costs $75 nationally on average per minute that the surgery is delayed. This graph here, the return of investment was reviewed with the stakeholders. I thought that this was a very important graph to show them. I took an example here of just the cost of the clinical concern for 10 canceled cases, which would be roughly, if we went on the high end, of $80,000. Compared to the cost of this program, our return of investment is very high in comparison to the cost that it would cost our organization to educate our nurses on health literacy, teach back in plain language. For surgical services, it is very important that we do not delay cases or cancel them. Obviously, patient safety is of utmost. The process of approval for my outcome involved the process that my hospital has implemented in place. I had to submit the project request with the evidence base to the hospital coordinator. We have an evidence-based project coordinator at the hospital. I had to prepare for the proposal. I had to get approval for my setting for my dates, the implementation date and an evaluation date. All of these had to be met prior to me beginning this process of implementation. Evaluation will include outcome measurements, the measurement tools that will be used by the team leader, which will be myself. Once a month, my manager and I will sit down. We will go over all of the canceled cases for the month and the reasons behind them. As the team leader, I will track delays for the OR. I will put these into a graph and we will review them. We will also, during our daily huddle, discuss these with our screening call nurses. The data within our system that is already collected will be a very vital tool for us. We will collect these. This is a tool that we have that nurses implement in the pre-operative area. They put in there the minute there's communication and education are linked directly to patient satisfaction, improved quality of care, and correct risk stratification. As a nurse who has worked in the peri-anesthesia area of nursing, I have seen the importance of proper risk stratification for patients who are undergoing surgery. As a nurse, I hope to be able to implement this practice change for not only our patients and families, but also the organization that I work for. As a nurse leader, the screening calls nurses that I work with, I hope to implement new processes that will support them as nurses in the place that they work so that they can be effective in what they do. As a future educator, I have learned a great deal about research-based, evidence-based practices